actually going to start off by telling you a story I think that illustrates the point about what we're trying to do in primary care here at Penn. This is a patient that I took care of a couple years ago whose care was pretty straightforward. A 70-year-old guy with a couple chronic medical conditions. I was really his only physician. I saw him a couple times a year. Care was simple. Until one day when he came into my office with flank pain and fever. I was worried about an infected kidney stone. I got a CAT scan. He did have an infected kidney stone on his left side, but surprisingly to both of us, he also had a 5-centimeter mass in his liver. This ultimately turned out to be a cholangiocarcinoma, a cancer of the bile duct, and from that point forward, his care became incredibly complex. And as his PCP, my job was to coordinate it all. And as you know, we talk a lot in policy circles about care coordination, but I think until you actually live it, either as a patient or a family member or a physician, you don't really know what it looks like. So what I did was all the care coordination activities I was doing, I started to keep a log of it. And at the end of 80 days, which was the duration between when we first got his diagnosis and when he had his tumor resected, I put it into this figure. So I'm going to play the figure for you. So this is in real time. In purple and blue, you see the phone calls and emails that I made, and in red and green, procedures and appointments that the patient had. And I think this will resonate with a lot of you who have either taken care of a complex patient, had a complex illness yourself, or had a family member. So on day 80, I got an email from the surgeon, short and to the point, but it was effective. It said, tumor is out. So at the end of the 80 days, I made 12 calls to the patient, 12 calls to other clinicians. I sent 28 emails to the other clinicians involved in his care. He had 5 procedures, 11 appointments, and I actually didn't see him once that entire time. I saw him when he had the kidney stone, before we knew he had cancer, and then I saw him after his tumor was resected. So all of that happened without a visit with me. So there's 2 main lessons in this story. Number 1 is that care coordination is hard to do. It takes time and skill and resources. And number 2 is that it's incredibly important. So there were several instances in the care of this patient where medical errors were averted because all the clinicians engaged in his care were communicating with each other. It wasn't done efficiently in this story. I did it all myself because otherwise no one would have done it. But it was important for him to get the care that he needed. So what we're trying to do at Penn, across our primary care network, about 500,000 patients who call a Penn PCP their primary care physician, we're trying to ensure that every patient gets their care coordinated like that, but that our providers have the tools and support to do that care coordination efficiently and effectively. So what does that look like? This is kind of our roadmap to primary care transformation and managing our population that we're accountable for through a variety of new policies and payment programs. The first 3 steps are all focused inside the primary care practice. So number 1, understanding who the population is, getting out of this long-standing mold of primary care where you treat the patient who's in front of you and you try to squeeze as much as you can into a 20-minute visit, but just take a step back and say, who's the population that I'm accountable for and who's calling me their primary care physician, me their quarterback? How do I identify that population? And step 2, how do I use our data to risk stratify them so that I understand not what their needs are when they come to tell me of a given issue, but that I know ahead of time what their needs are. Step 3 is expanding the care team role, so making greater use of non-physician and nurse practitioner members of the care team. Step 4, I just want to spend the last minute talking about, because this is a real transformation. The idea that primary care alone cannot manage a patient across the full continuum of care. It's essential that wraparound services are built so that the primary care team has those tools and those resources at their disposal to be able to meet the needs of the population.